Good morning, ladies and gentlemen. Psychological impact. As a medic, I trained as a haematologist. I had no actual training in psychological impact at all. I am a parent, so I've gone through psychological stress myself many a time and still do. But it's a partly very neglected part of care. Doctors are doctors, we're haematologists, we're oncologists, we specialise in that. And we have a bit of amateur skills as we go along on the psychological part of it, which we'll touch on as we go through. Because it does start with the doctor. The patient-doctor interaction is absolutely pivotal to actually how patients do, and it's not all about treatment by any means. And how many of you with CLL have actually been told that actually CLL is a good leukemia? Don't worry about your CLL. Oh, you've got cancer, it's leukemia. Don't worry about it. Don't worry. And has the doctor ever said, well, if you could pick a cancer, I'd pick this one? Who thinks doctors actually say that? About 50% of patients have had these three things said to them. Quite unbelievable. Especially if you take even early stage patients, those patients actually that you don't think we're going to automatically treat, they actually come with a whole list of symptoms which may or may not be related to their CLL. We are talking of a more elderly group with other comorbidities. 75% of patients will have other medical problems at presentation. But the tiredness is the biggest complaint that we see in CLL, and it's the hardest one to gauge. That you're tired, but you can be tired for lots of reasons as we get more mature in years, if I can put it that way. But there's a whole load of symptoms, and the doctor tells you not to worry about it. It's a good thing to have, you've got this. It's a good thing you've got tiredness. It's a good thing you've got CLL. And if you actually look down the bottom, the pointer plane, oh, sorry. What's happened to you? If you look down the bottom of the slide, when you actually look at the well-being reports, fatigue, pain, functional well-being and depressive symptoms, they are all higher in CLL patients, even in the very earliest stages of the disease. If you happen to have a past medical history of psychiatric disorder or depression, then actually the symptoms you feel on that list are markedly higher. And 25% of people actually get depressed throughout their lifetime. So a lot of patients with CLL have depression as well, which is actually exacerbated by the diagnosis. And when you actually ask patients what their concerns are, a lot of it, as we know, sorry about this, is concerns about their family and the loved ones. Even those with early stage disease are worried about it. And as your disease is more aggressive, those worries just go up. You care about your family, you care about your loved ones. We're not here on earth just to sort of breathe air and eat food and make each other miserable. We're here actually for your family and friends. Those are the biggest drivers for us. And that's what concerns an awful lot of patients. Uncertainty about whether their disease will progress, even for the early stage patients. That all affects your quality of life. Concerns about the side effects of treatment, and Ben's touched on that, and we'll touch a bit more later. Concerns about my children and relatives may develop CLL. 1 in 20 patients with CLL will have a family member, aunts, uncles. I've got about 4 families, and it's quite strange. I've got grandparents and grandchildren, I've got mother and children, I've got some of the children who've got it before the parents. And we now know there's about 24 genes described already which you can inherit. And if you inherited all 24, you're a phenomenally unusual person, probably inbreeding in the family, but we won't talk about that. You've got to be very unlucky, but even if you've inherited one, your risk is low, and we're unravelling that genetic link, and that's why some ethnic groups have a much lower incidence of CLL. They just haven't got the genes actually that predispose you to CLL. And it's probably true of most cancers, there's a genetic predisposition. Generally worried about CLL, worried about living with the symptoms of CLL, all those are patient concerns, with or without treatment. We actually look at the quality of life. How often do you think about your CLL? If you'll think about daily, which is 56% of patients think about their CLL every day, even though they've been told not to worry about it, it's a good thing to have. And of course, if you're worrying about it every day or thinking about it every day, your emotional score and your well-being is markedly lower. That gets less if you're thinking about it less, your scores actually improve. But a lot of patients just can't get away from the feeling it is always there. So if you've got CLL, you're trying to get a mortgage, you're trying to get a loan to buy a car or whatever, you put that on the form, or you think you're going to have to even put it on the form, it affects your life even if you're not having treatment. You can't get away from it. So back to our good old 3 questions at the beginning with the good old doctor. Do you feel you have a good understanding of CLL? 85% of patients said they thought they did, 50% said no, but those who said no had a much lower emotional score and quality of life. Do you feel your doctor has a good understanding of your disease? Thankfully, 90% of them thought the doctor did know something about it, so that's a bit of a relief all round. But surprise, surprise, those almost 10% who thought their doctor didn't know much about it, they were actually emotionally worse off and quality of life worse off. Do you feel comfortable talking to your doctor about the treatment and management? Again, we've got this 10% who really didn't feel they're in contact with their doctor in the way they wanted to be. Do you feel your doctor's good understanding of your CLL and how it's affecting your quality of life? And here the figure jumps up to 30%. So when you get on to what a lot of doctors would think are softer things of your quality of life, your well-being, what's the matter with you? You're walking around, you can still go to work. That's when the disconnect comes. That actually you don't feel the doctor has the full empathy and understanding of what you are going through. And I think that's true. As I say, we're haematologists or oncologists. Do you feel comfortable talking to your doctor about your CLL? 23% thought not. That's really considered such a pivotal part of the care, that doctor-patient relationship. Those figures are really quite alarming. And back to how often patients think about their CLL, this is a percentage thinking. 6 months after diagnosis, 83% are still thinking about it every day. 2 years after the diagnosis, 50% are still thinking about it every day, 2 years after they were given the diagnosis and they've had no treatment. It really is, it's real comorbidity just being told the diagnosis. So back to those 3 questions at the beginning. This is actually CLL a good leukemia. 33% of patients were told that by their doctor. Don't worry about your CLL, it's only leukemia, don't worry about that. 24%, if you could pick cancer, this is the one to have. 35%. My doctor never said any of those, none of the 3 above, it's actually 48%. So as I say, 50% of patients have had one of those ludicrous things said to them. Even though they estimated 90% of doctors understood CLL. Well, they don't understand it well enough, do they, if they're saying things like that to people. This is one of my favourite slides and one of my favourite studies ever. It always cheers me up. This is from the Mayo Clinic. So in the Mayo Clinic, it's a massive cancer centre. They just asked the doctors looking after CLL patients, do you think you're an expert in CLL? And some of them said, yes, I think I am. And the others said, well, not really, but I can do it because anyone can do CLL. And if you actually look at that, and just by self-nominating, they said what they were, obviously not knowing what the reason for the question was. The reason was, if they were going to go and look at how you actually managed your patients. And those doctors who described themselves as not experts treated patients earlier than the people who labelled themselves as experts. So if you're not with an expert, whatever the hell that means, then actually you're more likely to be treated earlier and probably inappropriately. Actually, survival, patients alive, if you're not under an expert, you're more likely not to be here down the road. And everyone follows guidelines and knows what the standard treatments are for the various patients. If you're getting the same treatment, why aren't you doing as well? Even better than this, even the trainee of the so-called expert is less likely to treat you than the non-expert. So a trainee is better than some specialist consultants who describe themselves as non-experts in CLL. We'll just move on. This is further data. When they carried on, that's all patients. This is actually early stage patients. And you can see this survival is significantly worse if you're under so-called non-expert, whatever that is. So I'd love to define what that is. And if you look at the demographics of the patients with CLL, unfortunately, it is something we're going to get as we get older, that actually we all get comorbidities. We're all falling apart at different rates as we get older in life. It's absolutely wonderful seeing myself fall apart. But the number of comorbidities you have goes up significantly with age, and that's before you've been diagnosed with your CLL. This is when patients presented. How many other comorbidities did they have? So you're not dealing with a pristine person who hasn't got other health issues. They most definitely do. And this really matters. This is a study from Germany, look at their CLL4 and CLL5 studies. The patients given exactly the same chemotherapy, in this case fludarabine cyclophosphamide, did significantly worse. In fact, if you had 2 or more comorbidities, even though you're getting the same chemotherapy, exactly the same treatment. So there's more to survival than the treatment. Other things matter a lot. So with those patients diagnosed early who are on the watch and wait, there should be a big discussion with them about how to try and keep well in case one day they are actually going to need treatment, because that will matter in the long run. Drinking, exercise, diet, all these things may come to play later on in life should you ever need treatment. With the effective treatment, this is actually the CLL4 study from the UK, where we compared chlorambucil, fludarabine cyclophosphamide. You actually survived better if you got fludarabine cyclophosphamide in this study. No news there, that's all well known. But actually, if you look at the well-being of patients, the quality of life, if you actually achieved a complete remission or a good response, surprise, surprise, your quality of life went up if your disease actually got knocked down and your symptoms got better. If you go on, though, and look at the various treatments with chlorambucil, your quality of life really didn't do much at all. It went up slightly if you responded. If you look at fludarabine, it went down a little, then recovered. But if you look at fludarabine cyclophosphamide, it actually drops down for about 6 months, and it takes about 12 months to get back to that quality of life you had before the treatment started. So the treatment itself, and whatever that treatment is, comes with a burden in terms of affecting your quality of life. And that should be discussed with the patients when you're choosing which treatment option is for you. But there's nothing to make people feel better than potential cure. And so we think the more patients we can get to no residual disease, the more likely we are to cure people. And if your disease is in remission, your quality of life improves markedly. So it's a way up. The more intensive therapy may make you feel poorly, but may give you the long-term benefit. And how to choose those is part of the skill of the so-called expert, I think. But what we've got coming along now for elderly patients with other comorbidities is drugs which are very, very different from chemotherapy. They're not chemotherapy at all. Chemotherapy is not cancer specific. It's a misunderstanding. Chemotherapy actually just kills the fastest growing cells in the body. That's all it does. And we now know that actually most cancers don't grow faster than the normal tissue, which is why chemotherapy doesn't work well in solid tumours, for example. But it's not by chance, it's your hair that falls out, the vomiting and diarrhea, infertility or infection, because your hair, the lining of the gut and your bone marrow are the fastest growing tissues in your body. And they're just innocent bystanders of chemotherapy. But what we've managed to do with CLL over many years and a worldwide effort over 20, 30 years is actually work out why the cells stay alive. What is unique about them? And Butin tyrosine kinase is a key player in a Butin-specific inhibitor of that. So in this early study, with the ibrutinib and look at the median age of the patient, 71. A lot of clinical trials, the median age is around 60. It's not really relevant, the data, for a lot of our patient groups. And of course, you've got to be fit enough to get into a clinical trial. They've got all these exclusion criteria for those people who are not so well. We don't want those rubbishing up our study. You know, people with heart disease, lung disease, or liver disease. But in the real world, these are the patients we are dealing with. These are the real people out there. But if you take the ibrutinib story, the very good things Ben touched upon is the side effect profile, the serious side effect profile is significantly lower. We couldn't give fludarabine cyclophosphamide rituximab to a lot of our patients with comorbidities, and even bendamustine rituximab is a problem. What these new agents will enable us to do is treat people in the path that we've just not been able to treat in the way we would have wanted. So for those with comorbidities, for those of you falling apart, there will be things later which won't actually make you worse. And the great thing about it is it's every bit as good as chemotherapy. So that old policy, a little bit of pain does you good with chemotherapy. We're going to give you treatment, beat you to within an inch of your life, because we've beaten your disease to within an inch of its life as well. Ibrutinib and the small molecule inhibitors that we're now having access to are going to completely change that paradigm of how things are. So for patients, I think a lot of the well-being is actually feeling you have some control over your disease and what is happening to you and the therapeutic choice. So knowledge is power, and patients can't have enough information, but getting information may not be easy. A lot of patients, they're a bit worried, intimidated by the doctor. Some places you pay by the minute. I can understand why you're a bit worried about that, asking questions. But when patients ask questions, it's a sign of strength in the patient. It's a sign the patient wants to do well. It's a sign the patient wants to join in on this journey to actually cope with this illness. So patients should never hesitate to ask their doctor questions if they don't understand. The doctor, of course, as we've touched on, is absolutely pivotal. The patient has to have confidence in the doctor. If you haven't got confidence in the doctor, you're just not going to do well. So if you haven't got that confidence, you really should be seeking another doctor. Source of advice, it's got to be accurate, up to date, and it's got to be pertinent to particular patients and the patient's situation that they are in. And a lot of information on the internet is out of date. Unless someone's keeping it up to date regularly, then actually it becomes a bit of a hindrance to you. I had a phone call a few years back from one of my patients asking me, could I write a letter to the local council to have them rehoused because their council house was unsuitable for them. And when I asked why, they said, my toilet is too near the sink in the bathroom. And they'd read on the internet that patients with CLL, the sink and the toilet should be at least 10 foot apart. And could I write to the council and say, must have a council house with the toilet and the sink 10 foot apart. A council house in the UK bathroom is usually something like 6 foot by 6 foot. So I wasn't quite sure how we were going to do that for them. But that absolutely petrified the patient, that every time they went to use their bathroom, that gap between the toilet and the bathroom, they thought was a threat to their life because of the infection risk. Absolute bloody nonsense. I haven't even got a toilet and sinks 10 feet apart. Yeah, ridiculous. Anyway, if you're sat on the loo and you can use your sink, it's actually quite handy, actually. But anyway, we won't go there. What I try to say to my patients is horizon scan. We all have ambitions. Our ambition is to have a good life, whatever that means for us. And we're all individual about what that actually means. But you had plans before someone told you you had CLL. And you've got to try your best to carry on with those plans. You know, thank God the kids have left me alone. Thank God they're not asking me for money anymore. It's me and my wife. It's our time. What's that, doctor? I've got a good leukemia. Oh, try and horizon scan. What were you planning to do? And is there any reason at all why you still can't carry on with that plan? And there may be very genuine reasons, but you can make obstacles for yourself. And we have a lot of patients. Is it okay for me to go abroad? Will I be safe on the plane? It's a 4-hour journey with people coughing. Life's for living. If you want to live like Michael Jackson and a little oxygen tent, well, bloody good for you. But that's no life at all. You've got to try and live your life, else there's no point in being it. And you've got to balance up that risk versus reward element to it. And some doctors, and I've seen them, oh, you shouldn't do this, you shouldn't do that. Oh, for God's sake, you may as well sit in your house, get depressed, and kill yourself. You haven't died of CLL, but bloody hell, you don't want to do that. Try and horizon scan. What actually were your plans? What things have you looked forward to in life? And why can't you still do it? Reach your goals. As I say, doctors fixate on treatment. In some parts of the world, that's what you get paid for. The more you treat, the more complicated the treatment, the more the ka-ching goes, or the cash till opening. Oh, you want an IV treatment? Ka-ching, wonderful, much better than oral. Absolutely great. We fixate on treatment, the doctors. But actually, the number of treatments we've got are increasing enormously. They're getting more sophisticated. We've got to learn how to use them. And for that, we need patient cooperation in studies. We've got more tools in the box than we've ever had before to fix the job. And I think we probably have enough tools in the box with all the new therapies coming through. I think we have. And we've got to learn how to use those tools in the individual patients we're working with. And the effect of the patient themselves, we often forget about the family, the partner. A lot of couples actually stop talking to each other. And the sort of conversation they have is the partner looks at the patient, the person with CLL, and says, how do you feel today, darling? And he says, oh, I feel fine. And you think, you lying bastard, you look absolutely crap. Why don't you tell me the truth? I'm your partner. We've been through worse than this. What people stop talking to each other. Getting cancer doesn't bring people together. If anything, it splits them apart. And you've got to work avidly on that and try and be honest with them. You can't lie to your partner. You've all tried. It doesn't work, does it? There was no dissent there, was there, when I said that? Yeah. And that general relationship, again, you're here for a purpose on earth. Those general relationships are important. Libido, nobody wants to talk about that. But actually, for some people, that's an important part of life. It's a sign of normality. This is normal behaviour. But that diagnosis will overhang everything. Of course, there's a worry about the children. The children actually, what the children think. The children often go on the internet and read things that worry them. And there's that gap between why haven't they spoken to me about this? Why my parents stopped talking to me? Because I've read on the internet all these things. And of course, it affects employability, writing on that actually you've got this diagnosis. Even if you don't need treatment, it affects insurance. You want travel insurance to go abroad. Some of our patients in the UK going to America, £800 for 2 weeks insurance, even with stage Y0 or stage A. Shop around for insurance because actually that's hindering your life. That this sort of cost that are just being laid on you. Insurance is not a gift. Insurance is actually a money-making business for insurance people. But employability and financial health, it's all affected by the diagnosis, especially if you need treatment, but even if you don't, quite often. And the doctors don't really understand that. Source of information, good and bad, written. Internet, there's good and bad, as I say. Patient groups, and mostly good. And the best ones are really very, very good. And a lot of it is what was driving behind why they set up the groups in the first place. They're a real source of knowledge, a real source of expertise. And of course, there's charities who do this sort of work as well. So when you're weighing up about the well-being of a patient, we're talking about organ function, we're talking about life expectancy unrelated to CLL. And a lot of our patients have had previous cancers now. They're surviving their previous cancers, living long enough to actually get CLL. And we're trying to weigh all that up with a comorbidity to come up with the best treatment for the patient, the thing that suits them best, that's likely to prolong their life with the minimum amount of inconvenience. And for some people, that will still be RFC, the most potent therapy, because actually that's the most proven treatment. And if you've got mutated VH genes, that's still by far and away the best. You see, you're going to have to try and manage patients with comorbidities, but the new drugs coming along are going to help us with that. So in conclusion, there's an enormous unmet need not filled by the healthcare profession in terms of what patients need to actually get on with their lives with CLL. We need more resources in hospitals, the governments need to do it, the charities, and the people like yourselves have an absolute pivotal role. That's why I was delighted to be asked to come here to see this group getting together who want to actually play a pivotal part in the well-being of patients. So the take-home message, with all the treatments we've got, the overwhelming majority of patients are going to have a normal life expectancy with or without treatment. The tools are getting into the box. We've got to learn how to use them. And we may actually get to the cure word. We're not there yet. We've got a bit of a way to go. And that's what should be being told to patients. There's an awful lot of work going on. I started CLL in 1989. We had chlorambucil only. And we thought we were doing well. All the very best, everyone, and take care.